Along those lines of preventing deterioration and decreasing pain, shortness of breath, all the things that limit their ability to do the things that really matter to them, which is what's really important. Thinking about for patients that, if we're able to extend this period of time, that patients end up on more toxic therapies, intravenous therapies, cytotoxic therapies, which have sort of a narrower therapeutic index. They typically require a lot more time in the cancer center,
Absolutely.
Which is its own toxicity. Certainly more higher grade toxicities, things of that nature. What do you think that means to patients, or what did patients express to you in the trial that, they were able to get significantly longer, time to end up on cytotoxic therapy?
Right.
And I think that's what the data has shown us, right? Patients got at least about 6 months longer, right? Till they had to go on to that cytotoxic therapy.
Yeah, you're right. So they reported time to, and they combined both at the time, because this was we have to remember the reference of this trial. There were not a lot of oral SERDs available. There were not a lot of the novel indications for ADCs at the time as we have today.
Right.
But they lumped it all together into any time to cytotoxic chemotherapy and ADC. And that time was in fact longer. And I think you're getting to a point that is one that we sit with our patients every day, which is when we talk about this transition from oral, when they become endocrine resistant and we have to go to IV, whether that's Xeloda or it's an IV chemotherapy, there is a clear shift in people's quality of life, right? From a lot of different angles.
Right.
One is alopecia, right? Now to the outside world,
People
I am now
they're sick.
a cancer patient, right? It is now official. It changes things dynamically for their family, for their friendships, for walking to the store, right? And picking up groceries feels different, right? That's an intangible concept that we cannot quantify in a clinical trial, right? This is what we hear every day. Right. That's one. And two, you mentioned more serious toxicities, right? So when we're shifting to ADCs, we're talking about things that actually, in some cases, can be life-threatening complications. Right. When I think back about, let's move from first line to second line in a PIK3CA positive patient, that's a hard transition, right? That's an even earlier transition, but it is hard because now we have to talk about hyperglycemia, diarrhea, mucositis. And there are a ton of different variables there. Although we have great drugs, it is still a transition nonetheless. And so I think that outcome is a tangibly soft landing for people to understand, for both us and for patients.
Right. And I think we kind of witness this, and what they share with us in their everyday lives. And so I think that's why most of us, think so significantly about delaying that time to cytotoxic therapy, because we kind of see what that means for them. And we understand, obviously, the increased toxicity and risk and all of those things.